As mentioned earlier, the board will now hold a special meeting as authorized by Government Code Sections 11125.3 and 11125.4 to consider proposed legislation. This special board meeting would allow the board the opportunity to consider proposed legislative amendments regarding controlled substances prescriptions and security forms requirements. As part of this special meeting, the board must first consider whether the delay necessitated by providing notice 10 days prior to the meeting would cause a substantial hardship on the board, or that immediate action is required to protect the public interest. For the board's consideration, as discussed during the Enforcement Committee report, the potential for significant patient harm resulted in the enactment of last year's Assembly Bill 1753, which altered the requirements for controlled substances security forms but failed to establish a transition period. Since enactment, the board staff has communicated the low priority for investigations of pharmacists dispensing based on non-compliant prescriptions. However, a permanent solution is necessary. The board's concern that patients are unable to receive medication necessitates immediate action by this board to convey its position on the proposed legislation and provide further guidance to pharmacists and pharmacies that may be hesitant to provide patient care because of liability concerns. In addition, AB 149 was amended to address this issue, but the amendment occurred after the publication of the board's full agenda. The cost and expense of calling an additional board meeting to consider this bill would cost the board a substantial hardship, and so there's a need to take action now. So I would entertain a motion from board members that the above establish sufficient necessity to convene this special meeting.
So moved.
Moved by Greg. Second by Stan. Any comment by the public or board members? If not, all those in favor, please raise your hand. Oh, you have comment? This is for the first special meeting. You have first we have to...
The need. They have to establish the need.
All right, all those in favor, please raise your hand.
It's unanimous?
Unanimous? Okay, so motion approved and we could proceed, right?
Correct.
So with the necessity having been established, I would now like the board to consider the provisions included in AB 149 as amended January 24th, 2019. As amended, AB 149 would delay the requirement for controlled substances security forms to include a uniquely serialized number until a date determined by the Department of Justice, that is no later than January 1st, 2020. It would also establish specifications for the serialized number. Further, this bill would make any prescription written on an otherwise valid prescription form prior to January 1, 2019, a valid prescription that may be filled until January 1st, 2021. Any discussions with the board members? So we need a motion. So if not, we'll need a motion to support this position.
Let me ask one question.
Yes.
So when you talk about the serialized number, we had somebody earlier.
Microphone.
So we talk about the serialized number, and we had somebody earlier, was it Valerie? Jennifer, who said that the serialized number is too long. It's 15 digits instead of 12. And will this take care of that as well?
Yes, as in its current form, it would require that the serialized number comply with NCPDP standards.
Okay, good.
Danny?
Hi, Danny Martinez, the California Pharmacists Association. So yes, we also support, we actually testified at the Business and Professions Committee on Tuesday in support of this bill. Just for clarification, the urgency clause was inserted during the committee process. I was told during this morning's meeting, the language went across the desk and the legislature should be in print tomorrow, but that is officially part of this bill. So it does have an urgency clause. We want to thank everyone involved in this process. I think this will relieve a lot of headaches that we've been seeing the last few weeks. If they're watching, thank you to the Business and Professions Committee staff as well for working with us, and ask for your support.
All right, thank you, Danny. So I need a motion.
Yeah.
Motion by Ricardo,
Second.
second by Greg. Any other comment? If not, all those in favor, please raise your hand.
It's unanimous.
Unanimous? Okay, so this motion is approved. So thank you all. So this concludes the special board meeting. Now we will return to the regular board meeting.
So how long would it take before this becomes, is this now the law of the land?
It hasn't passed yet, but as
So-
soon as it passes, it can become law
So
immediately.
So-
what is that timeline?
Okay, so actually, that's a good thing. I was going to raise that. What Danny said was that he's aware that an urgency clause has been inserted into this bill. As it's written now, in the version that at least I looked at yesterday, it wouldn't become law until January 1st, 2020, because that's the normal cycle. The urgency clause means that it takes effect right away, which would mean as soon as the legislature passes it, then it would become effective immediately. So it would.
Correct. So, yes, and obviously with the problem that has come up with the serial issue, with the serial number among other items, the expectation is that they're going to try and get this through the legislature as quickly as possible. I understand it's going to go to appropriations next week, is my understanding. Then it's going to go to the Assembly floor, going to repeat in the Senate. We're hopeful that this is done by the end of February, is what I've been hearing. And hopefully if and when the governor signs this, if you're listening, Governor, please sign this, that it'll go into effect the day after his signature is on the bill.
Right. So if the board wishes to speak to the urgency, I haven't checked I can check right now and see if it's online, but if the board would like to also take a motion to support that the bill be made an urgency measure, it could do that as well.
I would make that motion, because I think
All right.
it's a critical thing.
Yeah, okay.
So I make the motion.
Motion by Stan.
I second.
All right, second by Cheryl. Any further discussions? If not, all those in favor, please raise your hand.
Albert? Oh, there you go. It's unanimous.
Unanimous? Okay, thank you. Motion carry. Thank you. All right, any other public comments? If not, let's go back to our regular meeting. Agenda item number 7, Licensing Committee. The chairperson is Ms. Debbie Ville. Debbie?
Okay, thank you, President. Okay, so the first item, this is based on the licensing committee meeting that was held on December 19th. So the first item was pharmacy services during a declared state of emergency. Pursuant to Business Profession Code, Section 4062, a pharmacy furnishing dangerous drugs in reasonable quantity without a prescription during a federal, state, or local emergency. This section allows the board to waive application of any provisions of pharmacy law if, in the board's opinion, the waiver will aid the provision of patient care or the protection of the public health. Further, under this section, provisions exist to allow for the use of a mobile pharmacy under specified conditions. And additionally, in 4064, a prescription may be refilled by a pharmacist without a prescriber's authorization if the prescriber is unavailable to authorize a refill, and if, in the pharmacist's professional judgment, failure to refill the prescription might interrupt the patient's ongoing care. So as we all know, there were some pretty significant fires this past fall, both in Northern and in Southern California, and we did have to declare a state of emergency for these fires. And the board uses our subscriber alert system to get the message out, to let the pharmacists be aware. In addition, the duty inspector provides real-time guidance for any pharmacy or pharmacist that would call into the board offices. And this year, especially because of the campfire, because it just, wiped out a community, we had, situations where the pharmacies were actually closed, burned down, or that they sustained enough damage that they, weren't able to operate. And then we also had 6 pharmacies that had to close just because of the air quality in the area, that they couldn't open up. In addition to working with the licensee, the board staff also collaborates with other agencies within the state around disaster response, most notably the California Department of Public Health and the Offices of Emergency Services. And during the most recent emergency, the board disseminated information on the pharmacist's ability to care for the patient under emergency conditions, as I mentioned earlier, via the subscriber alert. So at our December meeting, we had a couple of gentlemen come to the meeting and talk about, how this how it all worked out this year. One was Tom Ahrens, a pharmacist contracted with the California Department of Public Health and is currently working at UC Davis, and Mark Chu, a pharmacist from the Orange County Emergency Services, as well as one of the respondents from the California Medical Assistance Team that helped during the camp and Woolsey fires. And so they, in the notes you can read, they provided a lot of information. They had a presentation about, it's tough during these fires. It's obviously very hard on our patients to get medication. A lot of cases, especially these 2 fires, they were out of their homes. So they were in shelters, and the shelters were just kind of a hodgepodge. Some of them were, 100% ready. They're ready to handle this type of situations. And some of them were Salvation Army, religious organizations, just everybody, churches, schools, opening up their doors to, bring in people. So the people that were running some of these shelters, they didn't always know how to, manage the situation. And likewise, what they had available for the patients. Sometimes they had medical supplies available that they could provide to the patients, and sometimes they had medical personnel writing prescriptions. And so these patients quite often were going to pharmacies, obviously not their own because they were burned down. And sometimes we came upon situations where the person was mainly from Northern California, but their family lived in San Diego. And so they went down to San Diego during this emergency for themselves, and perhaps the pharmacy in San Diego couldn't get a hold of the prescriber, and so sometimes the emergency situation expands beyond the tight little circle where the emergency is actually happening. So they talked about various problems that had happened with dispensing prescriptions and just kind of how we should, possibly address it. There was 3 specific things that they brought up during the campfire was, they had a group of methadone. There was apparently a methadone clinic that was impacted, and so then it was okay, so how do these folks get their medication? We don't want them to relapse. A pharmacy in the evacuated area that had not been destroyed was, they're worried about vandals coming in and stealing their medication. So, these things that you don't always think about. And then, of course, the board also received calls, unfortunately, from patients very worried because they can't get their prescriptions because they don't have any money to cover the copays. So we talked a little bit about that last situation. There is a program called EPAP, which helps people in that situation, but the one thing that we did learn from the 2 gentlemen that presented was EPAP is a fantastic program. However, it's only available to someone who has no insurance. And if, in this world, the average pharmacy, 99% of our patients have insurance. So this is a very small number of people that the EPAP would step in. And actually, at this meeting, I think they said they had seen 6 people. I happen to be part of the communication committee, and they came back to the communication committee to talk to us. I think they had seen 1 more. So this whole huge fire, the Camp and Woolsey fire, they had like 6 claims. So there's still kind of an issue, what happens if people can't, pay their co-pays? Some PBMs and health plans have override codes. We discussed that perhaps there needed to even be some sort of a program within the state that would offer, some sort of fund for that situation. But one of the big things that also came out of it is just the lack of knowledge of our pharmacists. And, part of it was because how often do you have an emergency of this capacity to really understand what you're able to do? I mean, we were talking earlier about, the prescription, the secured prescriptions. I mean, and this is like beyond, this is controlled drugs, this is everything. And that the pharmacists really didn't know exactly what they should do, and they were sometimes very hesitant to figure out what to do. So we thought, we should provide some sort of education program, figure out how to better get the message out, and looked at even creating a specific prescription blank form that could be used during emergencies, kind of similar to what's used for terminally ill patients, so that, if not everything's on the prescription, that it would, the pharmacist would know, I can still honor this prescription. So the committee decided what better to do as far as communication than to hand it over to Mr. Sanchez and the Communication and Education Committee to really kind of look at, how do we get the information out? Yeah, well, if you can ever pass the buck, you do it, right? So that's what we did, and I'm on that committee, and I know that we'll have a great report because we had some really good ideas out of that. So then there's other things that we needed to talk about is statutory change regarding the controlled substance prescriptions. So the committee directed the staff to work with myself, the committee chair, to develop a statutory proposal to create an exemption from the security prescription forms required for patients unable to access controlled medications as a result of the declared federal emergency. So in attachment 1, you'll see the draft language that we came up with. See if I can find it real quick.
But before that, Debbie?
Yep,
Have
please.
you guys talked about how they could work with the PBM to disclose certain patient ID information to the pharmacies that are willing to help them? I mean, oftentimes at fire, a person might come in with only their own ID, but they won't have all the insurance information. And when you go to the pharmacy try to help you to fill a prescription with no IDs at all. I mean, no patient insurance information. Will the PBM be cooperate under the circumstances to, sometimes when you call them, they won't give it to you. I mean, they won't give you the patient ID information.
So we did talk about that, and there's actually through SureScripts, if the health plan, the PBM provides the information, any pharmacy can do an eligibility check through their pharmacy system. And that's kind of part of what we handed over to the Communication Education Committee, is to maybe see if there's, best practices kind of something that they could put together so a pharmacy would know how to do an eligibility check, or how to approach it.
And also, they mentioned that they need some volunteer pharmacists during these kind of emergencies. Do they have a central bank or something who could collect pharmacists' information, the volunteers, and then they will know exactly what area to disseminate these pharmacists during that times, what is in Northern California, Central or Southern, they have a pool of volunteers to help them during the crisis?
So another thing that we want to encourage the pharmacists to do, and I think this is coming through the Communication Education Report also, is to sign up for your emergency disaster program within your county, because every county, like I'm in LA County, so I've signed up with that one. And then what ends up happening is once you're signed up, whenever there's an emergency, you get an email and actually a call. I think I get a text, an email, and a call, so that they can kind of hit you whatever. And if you respond, then they'll tell you, where you can go. And before, as part of signing up to be a disaster pharmacist, you kind of go in there and you put, I'm a pharmacist, I can do immunizations, or exactly what your qualifications are, so that they have this database So if you respond that I'm willing to go, that the emergency services folks know how to disseminate you. But so part of, the education is, how do you sign up for something like that, and how do you get involved? Because, it's like the more you do something, the more comfortable you become with it. So whether it be CE, or you go, like, I know the one in LA County, they have a class once a year that you can go to. So that's why we felt a big piece of it was just education, getting in front of the pharmacists, so that next time it happens, that they're just a little bit more comfortable. Because that's one of the things we found out, was they just weren't comfortable.
Oh, yeah, I'm
with
sure.
how to-
They may be willing to volunteer, but they will be hesitant to do a lot of other stuff if they don't know that it's legal to do so.
Yeah, yeah. So in my county, in LA County, the LA County Disaster Preparedness, they put on it's usually in June, and they organize the class. And it's like an all-day thing. And I think other counties do. It sounds like, I know Orange County does it, but it sounds like other counties do it too.
Good.
So the statutory change regarding controlled substances is going to be Health and Safety Code Section 11159.25. And it says, A, notwithstanding any provisions of the law, if the California State Board of Pharmacy issues a notification pursuant to BPC Code 4062, a pharmacist may fill a prescription for a controlled substance for use by a patient who cannot access medication as a result of a declared state or federal emergency, regardless of whether the prescription form meets the requirement of Section 11162.1. If the prescription meets the following requirements: 1, contains the information specified in Section 11164. 2, indicates the patient is affected by a declared emergency by the words 11159.25 exemption. And C, a pharmacist filling such prescription must review the patient's activity report from the Prescription Drug Monitoring Program prior to dispensing the medication. And we kind of added in that C just to make sure that, we don't have drug seekers, honestly, taking advantage of, a horrible situation and filling their medications. I know our interim executive officer talked to an office, because this would have to be carried as part of a bill, and they thought that they would be interested in this, but they kind of wanted to put, maybe it would only be good for like one fill or 2 weeks or whatever. I don't know if you want to.
Yeah, so the consideration that the language does not include, and where policy guidance would be helpful, is a declared emergency can last for a long period of time. And the presentations that were made really talked about this is at the very beginning when there's a critical need, and that the needs of patients change and access changes as you go forward. So this would probably be appropriate at the very beginning of a declared emergency, but perhaps once stabilization is there, it's no longer necessary. So where the policy direction would be helpful is, as we're building additional parameters for this, would the board feel comfortable, if you feel comfortable with the general policy, should it be limited to a single fill? Should it be limited to a 2-week period after controls? Because as a declared emergency can last a long time, this limited exception should not create an avenue for people that otherwise should not be receiving the medicine to get it.
And specifically, this is around controlled drugs.
Correct.
So we're not talking about the blood pressure medication, we're talking about the controlled drugs. So the motion from the committee, I need to kind of put it aside, because we not only are we going to direct staff to secure an author to sponsor this language, but also we're now proposing that we add one other thing to this language, and that is a timeline. So I don't know, is one fill, is that too restrictive? Is a 2-week window? I mean, what is our opinion? And then we probably need to fold that into our proposal here. Does anyone have an opinion?
Public comment?
Steve Gray.
You're not, your mic's not on.
Thank you. Steve Gray, I would suggest a little bit more wiggle room, and I don't mean that in a negative way. What the federal law allows for the refill of a controlled substance prescription under 4064 is that you can, under California law and policy has been for 4064, which is refill without being able to reach the prescriber to get a refill authorization, is the pharmacist can use professional judgment, and that should be put in here, that you're going to hold the pharmacist responsible for professional judgment, and can actually refill a non-controlled substance for the full amount. But for a controlled substance, the federal law requires that it can only be filled for a period of time that in the pharmacist's judgment would be reasonable to reach the prescriber. So rather than saying 1 week, 2 weeks, 3 weeks, the people in a disaster are going to know what's going on. They're going to know that I'm not going to reach this guy for a month. But I'm not going to go beyond a month because within a month, this patient can go see another doctor down in San Diego or something, wherever they are, right? So rather than pick a time certain, I would rather it mirror the current law for refill without a prescription, which is the pharmacist has to use professional judgment. And for a controlled substance, it would be the judgment within a reasonable time for the patient to, or for the pharmacist to be able to reach the prescriber, something of that nature, as a suggestion.
The refill part, that's already law.
That's already law.
Right, and you're right, that's already professional judgment. I know, Laura, do you have an opinion about reasonable time?
It doesn't concern, if what you're tying it to is the pharmacist's professional judgment, a reasonable period of time in the pharmacist's professional judgment, I think that that's okay in a statute, because we run into trouble with it at the Office of Administrative Law when we use that language, because it's hard to say when, or it can be hard to say when that is, but I think in a statute it won't be a concern.
And that mimics exactly what the advice we got for 4064. Put it in the statute. The second thing I want to suggest is on 1159.2, which creates the exemption for the secure prescription blank, for a patient that is hospice or terminally ill. Right. What we learned from that was you don't want to have every prescriber have to remember a code number. They just don't do it. And so in the other 11159.2, we talk about, or words of similar import, or that the patient is known, in the professional judgment of the pharmacist knows this patient is a hospice patient or terminally ill. So rather than tie it specifically to 11159.265 or what, put other words in there that give, again, some latitude there for professional judgment.
Okay. Do you have any concerns with that?
This is really intended for a new prescription, not a refill.
Right, yes.
And so that's why I think that there may be problems getting it through the legislature if it's as deemed reasonable by a pharmacist's professional judgment. I'm not weighing in on the policy. I'm just saying that might create problems getting it through the legislature because there's a lot of concern about potential abuse. So I think that if the board is agreeable, giving staff some policy direction that you're okay with us putting some kind of fence around and maybe authorize us to work with either the chair of the Ledge Reg Committee or the chair of the Licensing Committee to make sure that we don't go too far. But I do think that there may be problems effectuating the overall policy goal if it's not a little bit more specific as to what a time period would be.
Because you talked to a possible author, and that's who gave us the feedback. And did they seem like they wanted more of a time period?
So they did not specify whether it should be a time period or a limit on the number of fills. But I think either approach would be fine. Again, the concern is we don't want to create a loophole for drug seekers.
Yeah,
So
absolutely.
one possible hybrid could be within the pharmacist's professional judgment, but no more than.
Okay.
So like the outside window, would that address the concerns, do you think?
Yeah. Maybe no more than like 2 weeks? Is 14 days enough, or?
Well, it depends on the disaster.
Yes, Steve Gray again. Just please keep in mind that this particular thing you're talking about in a disaster is not just Schedule 2, which 11159.2 was really trying to address. So it could be something for attention deficit disorder, which is an ongoing thing. And also for 4064, what we said back then was it talks about refill, but it may be a new piece of paper. It may be something new, and we don't want to confuse people that, you know, the professional part of the professional judgment is a discussion with the patient and whoever else is there, that this is ongoing and therapy, you know, like methylphenidate, or like one of the anti-anxiety drugs that they need, or anything that is a controlled substance, because this is now talking about all controlled substances, including Schedule 5, you know. So I always give the example of, you know, person has chronic diarrhea, so are you really going to limit them on getting Lomotil? You know, that type of thing. So just kind of keep that in mind too, that to a pharmacist who's black and white thinker, well, it's a new piece of paper, but they've been getting it for years. Do I treat it as a refill? And you remember, you have language in the consultation which doesn't say, it talks about you know, something that has been ongoing therapy, even though it's a new piece of paper, doesn't need consultation. You see what I mean? So think of it, don't think new piece of paper, therefore new prescription. It may be ongoing therapy.
Well, I think this is specifically directed at controlled substances, because I think 4064, you know, is all focused, like you just said, around not interrupting the patient's ongoing care. And so this is basically, this is getting around the security prescription. All right, so if we amend our proposed language to include, and I think Section 2 indicates the patient is affected by a declared emergency by words 1159.25 exemption or similar language, and then put in there somewhere upon pharmacist professional judgment up to 2 weeks. That would, I think, be the motion that I'll put out if somebody wants to second it.
And this is your committee recommendation?
It's not committee because we're changing it, so I think Ricardo just seconded it.
Okay, so motion by Debbie and second by Ricardo. Any comments by board members? Public? If not, all those in favor, please raise your hand.
It's unanimous.
Unanimous? Okay, motion carried.
Okay, thank you. Moving on to, yes.
Steve Gray again. I remember at the licensing committee, I raised the issue, and I didn't see it in the report, and maybe I just didn't see it because I'm old. One of the confusion that has been ongoing about emergencies is that sometimes the pharmacists don't realize that the emergency was in the Redding, California area, you know, for this campfire, right? And the whole area was destroyed. And so the patients evacuate and they go to Sacramento, or they go to San Francisco, or, you know, Bakersfield, wherever they've got relatives. The pharmacists in these parts of the state that are outside the declared emergency area, they don't know if the law lets them now take care of those, because it's confusing. You know, this part of the state was a declared emergency, and Southern California was declared emergency, and the people that had to evacuate went to some other part of the state. Does the ability that we're talking about, a pharmacist to fill those prescriptions and et cetera, does it apply to Fresno? And all I'm saying is that we get that question over and over again, and I don't know whether it's a problem with the law and the way it's stated about the declared emergency area, or whether it's a problem with our communication when we educate the pharmacists that say it's the patients and wherever they are that need this relief. And in cases, and the campfire was a great example, because that whole area was so destroyed, everybody left. There was no more. I think that what they talked about was Chico to Sacramento. Every hotel was filled, and people were, even if they didn't have relatives, were having to go to Merced and Modesto or wherever they could find some place to stay. So I don't know if it's a communication and the way it's worded or the language, but I think we need to recognize that the need is not necessarily in the declared emergency geography.
So
Thank you.
when we were drafting this with the chair's input, that comment had been taken into account, and if you notice, the language actually specifically says, for use by a patient who cannot access medications as a result of a declared state or federal emergency. So there's no restriction on where it occurs.
So is there any concern about fraud?
Absolutely, there's concern about fraud. And that's why we are asking them that they have to check the cure system. And that's why we're putting a limit on it, and, and getting the doctor to put that disclaimer.
My remark is really to Steve, where somebody goes into another area and with the expectation of being accommodated, and is there possibly fraudulently.
Yeah. But yeah, thanks, Steve. I tried to make that point earlier when I said the person went down to San Diego, but I think you did a better job of focusing on it. Are there any other comments? Did we answer your, Stan, did you want to have, did we take care of your comment? Okay. Moving on to item B.
And I'm having a delicious Hershey. Otherwise, I would have responded even quicker.
Summary of discussion of inspection of sterile compounding pharmacies as a result of a remodel. So pursuant to BPC section 4127.1 and 4127.2, a license to compound sterile drug products shall not be issued or renewed until the location is inspected by the board and found to be in compliance, and a fee is assessed for issuance of a renewal of a sterile compounding license. At the October 2018 board meeting, at the recommendation of the Enforcement Committee, this issue was forwarded on to licensing, and it had to do with when sterile compounding pharmacies are remodeled. Because currently there's no requirement in pharmacy law for the board to conduct an inspection of a sterile compounding pharmacy after a remodel, which I think is, kind of shocking. The board is mandated by law to ensure that the sterile compounding pharmacies are in compliance with the law. So as such, we do inspect remodeled pharmacies. And such inspection is really necessary to make sure that they're in compliance and, it's going to be safe for the consumers. And this is similar to CETA guidelines that establish recertification of equipment when there's changes. So under current law, the board does not have the authority to assess a fee for such an inspection. Since July 2015, the board has completed approximately 65 sterile compounding remodel inspections. And normally what has happened is, as soon as the board is aware that a pharmacy needs to be has been remodeled, they'll lickety-split try to get out there and inspect it before they do reopen. The scope of the remodel ranges from simple projects to a full remodel or an expansion, and there are several reasons for the remodel: unforeseen damage, they want to expand, they're upgrading, perhaps compliance with the law. Currently, when the board staff is notified of a pending remodel to sterile compounding, they attempt to conduct the inspection as soon as possible after receiving the notification. And most remodel inspection requests are planned projects, so for the most part, the facility knows we're remodeling, here's our scope and our timeline. So with that, we had quite a bit of discussion about trying to establish parameters, because obviously we're not trying to really collect another fee. So our goal is not, let's get them with the remodel and get them again in a couple months when they renew. So our discussion was, how do we make this work so that we inspect them for the remodel, and then literally if in a couple months their renewal comes up, why can't that just be one fee? Because we feel very strongly that we spend a lot of money sending inspectors out to inspect the remodeled pharmacies, and that's super important to do, and that we should be able to charge a fee for that because of the cost. And with the constantly changing and moving to the new USP chapters, we're anticipating there could be quite a few remodels coming up. So what we discussed was a couple things. First off, establishing some sort of a notification parameters for a pharmacy to advise the board when the remodel is planned. And possible consideration to develop a remodel application for the facility to kind of go through so we know exactly what they're doing, because there are situations, and actually I think, Steve, you brought it up, that there are situations where they're doing a remodel, but it's pretty minor. They're swapping out a door and doing something that maybe doesn't really matter, or maybe swapping out that door is a big thing. So by going through this this remodel application, it could be easily determined, if an inspection is actually needed or not. And then also, if the inspection or the remodel is close enough to the renewal, what is the right number, what is the right time period to honor, to say that remodel is paying the remodel fee, then also pays for the renewal. So the committee landed at 90 days. That placing a parameter in law to specify if a remodel inspection occurs within 90 days of the expiration of a license, then the inspection would serve also as a renewal inspection. And if I remember right, for sterile compounding, they renew once a year, right? So, they're going to get re-inspected every year and renewed every year. So we asked, the committee asked the staff to kind of start working with legal to develop language and really look at this stuff and come back to us at the next meeting. So we don't really have anything for the board to vote on today, just kind of an update of where we are. But before I go on, we are interested in if there's any comments from the board members. I mean, hopefully you think we're going down the right road and you're in agreement. Public? Is this where you're going to say something that I might scream at you about?
It might.
Okay.
What's that? Oh. Danny Martinez, the California Pharmacists Association. So first, I had two things, but I think hearing the commentary, I think one of the concerns that I had was addressed in terms of the parameters. That's something that we'll evaluate and have comment on at the next licensing meeting.
Well, and hopefully you'll provide feedback to
Correct.
kind of help us go down that road.
Yes. So, but the second concern still remains. It actually remained. I was unable to attend the last licensing committee due to jury duty. I didn't see this in the minutes, so I'd like to, if the president would indulge me, I'd like to read a statement that I had on the issue of the fee. The board staff is recommending enacting a fee, which I believe, and somebody can correct me if I'm wrong, totals $1,325, which is similar to the sterile compounding licensing renewal amount. The staff's justification is that currently the board is absorbing the cost of the remodeling, and some of these inspections are very costly, both in time and in money. However, the board just voted to increase all licensing fees to the statutory maximum, including sterile compounding. Specifically, the new compounding license is $2,305. The temporary license is now $715, and the renewal is $1,855. When you total that up for everything, that amounts to $4,875 that, in terms of fees of which compounders are going to have to pay, and as an increase, from the previous fees. So that's what they're paying each more. And when you multiply that by all the current sterile compounding licenses that are active, and which according to the board's website is 932, that's an extra $1.2 million per year that the board is going to be bringing in with these new fees. What's that? I'm almost there. This clearly demonstrates that if the board is going to create regulations on remodel inspections, there should be enough money to cover this with the new fee increase. And I would also ask that you consider that, as mentioned, in the last 3 years, there's only been 65 remodel inspections, which amounts to just over 22 per year. I would strongly urge you to reconsider applying this fee in light of the recent fee increase. And, as I mentioned, the parameter argument, I think, is already taken care of, or at least will be taken care of at the next committee meeting. But we're strongly urging you to reconsider this fee in light of the recent fee increases.
And actually, I thought we did read his letter at the meeting, and I thought there were some comments that the math wasn't exactly right. Can you talk to that?
So, sorry, I don't have the figures in front of me. I don't know why it won't stand. I don't have the figures. There we go. I don't have the figures in front of me. We're happy to bring that back to the committee, do the math, and tell you what we think that it is. I think that there's some assumptions being made as part of the math that I don't know that we necessarily agree with. I will comment that the number of remodels that we've done over the last several years is low, but as pharmacies are moving to remodel to achieve compliance with USP 800 requirements, we do believe that there will be an increase in that workload.
And I wasn't saying that you didn't read this. I'm just saying it wasn't reflected in the minutes. That's why I was bringing it up at this meeting. I think the point remains, though, that with the new increase specifically to sterile compounding fees, whether the math is off by, I don't think it is, but I mean, we'll see. I still think there's a point to be made that there's a substantial amount of fee revenue coming in starting in 2020 that I think the board should look at as the source to pay for these instead of assessing a new fee. But that's our position, and we'd ask you to please, we'll be asking the licensing committee to please reconsider that.
And I think what we were trying to do is eliminate that duplication, the renewal and the remodel, so there'd only be one.
I mean, look, I can speak more to that at the licensing committee. I think there will be circumstances where you might see sterile licensed compounders delay remodels specifically for that. And given the arguments that I've heard about patient care and specifically relating to sterile compounding, is it in the best interest for compounders to wait for that remodel until they get to that point? Because now you're potentially talking about facilities that may not be 100% compliant, but unless they actually remodel, you'll never know. There's a risk involved with that. And again, I would have made these points at the licensing committee, and duty calls. But maybe I'll just reiterate those at the next licensing committee, and we can further flesh that out.
Okay, thanks.
Well, Danny, I could say is with anything, there's some cost associated to it. I understand there's the cost in doing the remodeling and also getting the license, but there's also cost in extra on our inspector time and travel to go to the location to do the inspection.
Right.
Particularly for sterile compounding, if there's some of the stuff are not specified to our compliance, they will be subject to cite and violations.
Right.
And actually, let me tell you, if they could be cited, it could be at least a $5,000 fine, which could eliminate whatever savings that you think you might have. And also, plus, when the board is heading into a new direction of educating the pharmacists, which I strongly support this role.
As do we.
And will be pretty much eliminate a lot of the fines that could have imposed on a lot of these pharmacy. And then you think about some of these money, all these fines that came up for that source would be eliminated. Okay, I mean, I don't know between the choice of A or B and which way you want me to go, but
Right.
I strongly would rather be educating the pharmacists
Right.
to do the right thing than to punishing, to impose a severe fine for compliance.
I don't disagree with anything that you said. All I'm stating is that the board is going to be seeing increased revenues from this fee increase, and it's substantial.
We are working very hard to balance our budget. That everybody have their own things to do, and actually we're all working to do the same goal.
Okay.
Without overtly increasing the fee, increase the burden of all the licensees.
Understood. Thank you.
Thank you.
See, I didn't even have to yell at you, Danny. Okay, moving on to item C, discussion consideration of self-assessment requirement for the ADD systems. I think we've already talked about Governor Brown signing AB 2037 and SB 1447, both relating to licensure and use of the ADD systems. Both measures require the operating pharmacy to complete an annual self-assessment to ensure compliance with pharmacy law as it relates to the ADDS. To facilitate the implementation of this requirement and promulgation of the regulation is necessary. So at our discussion, at our committee, we reviewed some proposed self-assessment of ADDS by the pharmacist in charge. And I think they're attached here, and you can see they're quite lengthy. But the goal was to help the pharmacist in charge really kind of go through and make sure that they have all their I's dotted and their T's crossed, and that they are in compliance. We also discussed a slight change in the regulation by adding a comma and the word "or" at the end of paragraph 2 of subdivision B, where it said there is a, because basically you're going to do a self-assessment annually before July 1st of every year. In addition, the self-assessment is required when a pharmacist in charge, within 30 days of a pharmacist in charge, either adding a new ADDS license or a change in the pharmacist in charge, and he or she becomes a new pharmacist in charge, comma, or there is a change in the license location of the ADDS to a new address. So the committee motion was to recommend to the full board to approve the draft language with the change with the comma and the or, and to direct staff to initiate rulemaking with the intent to have the regulation in place by May 1st, 2020. So that was a committee motion. No second is needed.
Okay, this is the committee recommendation. Board members, any comments? Seeing none. Public comments? None. Okay. For all those in favor, please raise your hand.
Unanimous.
Unanimous? Okay. Motion carried.
Thank you. And in addition, the committee also went through the self-assessment forms and made some changes to hopefully make them, actually, the staff did a great job with the forms that they had, and we just made some minor changes that we thought would just kind of help the pharmacist in charge complete them. So our recommendation is we are having the staff make necessary changes as discussed in the draft regulation and draft assessment of the ADDS to bring to the full board. Is that...
I believe
are the
that
changes
the
all
changes are
reflected?
incorporated.
Okay. So I think, our motion is that we accept the self-assessment form as presented in your materials.
And I think that was probably incorporated into the prior motion, because
Okay.
you would be adopting the reg language with the model self-assessment form. The one thing that you might want to add, and I apologize that I may have missed this during the committee meeting, but you might also want to authorize the executive officer to make clarifying changes to the text of the reg or the self-assessment as needed. That may be necessary in the rulemaking process on the clarifying so that they're consistent with the board's policies.
All right.
Okay.
You want to
So
make
I'll
the
make
motion?
that- I'll
Okay,
make that
Debbie
motion.
made the motion. Need a second? Second by Stan. Any discussion, board members? Public? If not, all those in favor, please raise your hand.
It's unanimous?
Unanimous? Okay, motion carried.
Next is the policy statement regarding the medication-assisted treatment. As everyone knows, and we've talked about already today, there's a huge national opioid crisis. And one of the recommended solutions to address the crisis is to provide a medication-assisted treatment, otherwise known as MAT, to help wean patients from opioids. There are 3 medications used for this: methadone, buprenorphine, and naltrexone. California legislature, recognizes pharmacists as healthcare providers, and through the advanced practice pharmacists, they recognize our skills to manage patients and provide direct patient care. So with the skill set that we have, we're positioned well to provide care to patients with opioid addiction and assist other medical providers in caring for this population, thereby expanding the access to treatment. Currently, the federal law prevents a pharmacist from prescribing MAT for opioid addiction. A pharmacist is not eligible to obtain a federal DATA 2000 waiver to prescribe buprenorphine. Pursuant to the federal regulation, the only healthcare providers who have the authority are currently physicians, nurse practitioners, and physician's assistants. Expanding this authority to pharmacists would allow pharmacists to fully exercise their pharmaceutical education and experience in this area of healthcare. And additionally, expanding the authority increases the number and availability of healthcare providers in California specifically. So during the October 2018 meeting, the board directed the staff to draft a policy statement supporting the role of pharmacists in providing MAT, as well as developing options for advocating. So the committee discussed the draft policy statement that the staff provided and possible ways to advocate. The discussion encouraged NABP to adopt the policy since they're a national organization. The committee also discussed the need to work with a coalition of other groups, APHA, California Healthcare Foundation, the California Pharmacists Association, the California Society of Health System Pharmacists, schools of pharmacies, and any other interested party we could honestly find. And actually, since then, we have had an email from a specific interested party within California that would be willing to work with the board to promote our policy statement. Generally, the comments we heard from the public during this meeting were in support of a policy and support of adopting the policy statement as provided. So the committee recommendation motion is recommend to the board to adopt this policy statement, encourage that NABP establish this policy language as a model law for all states nationwide, work with APHA, CPHA, and other national organizations to implement this into federal law. And then, thank you. And then,
I make her sick sometimes.
and so let's vote on that first. That was a committee motion, so there's no second necessary.
Okay, well, I believe that the primary mission of the board is for protection of the consumers, but that doesn't mean that the board cannot be a strong advocacy for the profession. And this is a very good example that in this new era, I think the board should take a different direction. If we haven't done this in the past, we have to do better in the future, is to be a strong advocate of the profession so they could create more position for pharmacists and expand the scope of practice for pharmacists so the professional could flourish, and so will be the board. So I strongly support the committee in supporting this motion. Okay, any other board members comment? Public?
As one of the entities in Ms. Veal's report, we wholeheartedly support this, and we look forward to working with the board and our national partners, APHA and CPA, a couple other folks, to disseminate this as much as possible. Let us know what we can do.
Thank you. Steve?
Steve Gray, individual pharmacist. First of all, I fully support this concept and the development of a policy, and I think that will go a long way for California to show some leadership and will help get this at not only the national level but at other states. However, I think that this is a big patient care issue. There is a huge shortage of practitioners that can manage the therapy of buprenorphine and other MAT-type drugs. And in fact, one of the biggest advocates of changing the situation so that pharmacists can do this was the Department of Healthcare Services. About 2 or 3 years ago, I believe it was at a communications committee meeting, the Department of Healthcare Services, realizing they had a big problem, came there and asked for the board's help to do whatever it takes to help get pharmacists be able to manage these therapies. And the data that they released at that meeting was shocking. It showed that the overdose death rate for counties above Sacramento, counties above Santa Rosa, was 25, in the neighborhood of 25 per 100,000 per year. In counties below that, Sacramento, it was rated to 4 to 5 per 100,000 per year. And so why was that? The reason was there was a huge shortage of physicians and other practitioners that would take this on in those Northern California counties, and especially for Medi-Cal patients. And so there is a big problem with having enough. This is being complicated, quite frankly, because there's also a big demand for more practitioners for mental health care. And often the abuse of drugs follows very closely with mental health care patients because in one example, they're desperate. They need something, and they get into drugs just to help manage the psychosis themselves. So I think in addition to adopting this policy, and I think I mentioned this at the licensing committee, I believe that this board should go a step further and maybe discuss it in the Leg and Reg committee this afternoon, and that is to actually go ahead and take this opportunity, this need now that is in the minds of everybody, and sponsor legislation that will actually change California law if necessary, so that once the federal law is changed, pharmacists can actually do this. We did that before. We were the first in the country to recognize the use of computers in pharmacy, central fill pharmacies, and so that when the federal law changed, we were ready to we didn't have to go through another year of legislative effort to go ahead and implement that. We are very optimistic at the national level that this is going to be approved this year. And unlike state law, if it's approved at the federal level, it goes into effect immediately. Okay. Wouldn't it be great if California law, if necessary, was already able to say to pharmacists, as collaborative practice, as advanced practice pharmacists, whatever it takes, you are able to manage the MAT therapy of these addicts and take some of the burden not only off the patients, but the other practitioners that are struggling. Thank you.
Thank you. Question.
Would you feel qualified to do this? In other words, if we, allowed this, how many pharmacists do you think would be qualified to do this? Or would there have to be some special training that they go through? And how would one determine whether to use methadone, Suboxone, or naltrexone?
Yeah. Methadone is probably a separate issue. Let's set that one aside for a minute. But the buprenorphine products and other products, that's why they changed the name to MAT, because there's other products about to be introduced on the market, so that it's medication-assisted treatment regardless. Anything approved by the federal government is now called a MAT, and it's not limited to those two drugs, buprenorphine and methadone. I believe that the fundamental parameters that already allow California pharmacists to do collaborative drug therapy management and advanced practice sets them up to do it. Now, they would have to have that kind of training, but in order for them to get their special DEA number, they would have to go through the same special training that nurse practitioners, physicians, and others would do. So as soon as we're sure that the federal law is passed, we need to be ready to say to these pharmacists, okay, go ahead, apply for your SAMHSA, because there won't be any state barrier to you going forward.
Okay.
So actually, after this motion, the next part of my report is that our legal counsel was to determine if the change in statute is going to be necessary.
I was going to jump in and offer that. I'm not aware that a change in state law is required, so if Mr. Gray believes that is, then perhaps he can come talk to us later, talk to me later on the side, and we'll talk about what his concerns are. But at this point, I don't think that there's anything that would prohibit it under the existing provisions relating to collaborative practice. Okay.
Fred Mayer,
Yeah, Fred.
Pharmacist Planning Services. In 1974, I owned a drugstore called Sausalito Pharmacy in Sausalito, California. We did the first program on methadone, and it was a nice, simple program. We had a psychiatrist in town who wrote prescriptions for heroin addicts, 10 of them, and at that time you could write it. They'd come into the drugstore. We would open the pharmacy from 8 to 9. All the patients, the heroin from marvelous Marin, wealthiest county of all of Marin County, would come in, and we would give them out methadone dissolved in orange juice. And it worked well for 2 years till the federal government came in. It took the methadone program away. But the point I tried to make, it's very simple. We did a pilot program. We published the pilot program. 10 addicts came in, and we had them for at least 2 years until the federal government stepped in. It's not difficult, and methadone is easy to control. And right out of the pharmacy, we had no problem whatsoever.
Thank you. Okay. Any other public comments? Board comments? Okay, so this is a committee recommendation. And so all those in favor, please raise your hand. Unanimous? Okay, motion carried.
Question that. So, what relationship do we have with the American Pharmaceutical Association, or what relationship does CPHA have with it, or are we? I know that our previous executive officer involved herself with NABP quite a bit at the national level. So, where are we with collaborating with either the national organization or the state board organization in an effort to be able to accomplish more than we can accomplish just by ourselves?
Do you want to, I mean, I think part of it, we're waiting for this vote, but I'm not sure if you've been,
Before Ms. Harold retired, she had reached out to several national players, advising them that this was on the radar for the board for action. And so we do have some introductory players to start with. With the NABP specifically, I believe that they also have a strong network, and they also advocate at the federal level. So I do think in terms of disseminating the policy and advocating for the changes at the national level, where we are one voice, we're not the only voice, and there's probably voices that are bigger than ours to do it, but that doesn't mean that we shouldn't participate in the process and try to encourage the ball moving forward. The other thing that I'll say that we'll hopefully be bringing back to the committee is some other possible options for MAT services specific to naltrexone that may not have the same limitations as the methadone and buprenorphine have. So we've been doing some research in that area, and there may be some things that can be done in California even before changes happen at the federal level to at least get the ball moving in the right direction.
thank you, Ann. So the agenda item E is the review of licensing statistics, which are attachment 4 in your packet. Just a high level, we've received 8,992 applications. We've issued 6,608 licenses, renewed 33,193 licenses, currently have 140,820 active licenses. One of the things that we're constantly working on and talking about in our licensing committee is processing time, with the standard of 30 days to process applications and standard 10-day for processing deficiency mail applications or responses. And you can see in the board packet that we're close. We're not exactly there on everything, but I think we're continuing to improve. And I think the board staff is doing everything they can to try to triage and work around it to try to hit our goals to be responsive. Is there anything? I don't know, Anna. Is there anything you want to add? Anything from the board members or public? Otherwise, the next licensing committee meeting is going to be April 3rd, followed by June 26th and October 2nd. And if you missed the meeting on the 19th, like Danny did, you can read all about what happened on the 19th in attachment 5. Mr. President, I'm submitting my report.
Thank you, Debbie, and your committee members for your hard work. Before we go any further, let's take a 5-minute break before we go on to the next agenda item. Thank you. Okay, we are back in session. Let's move on to agenda item number 8, the Communication and Public Education Committee, and the chairperson is Mr. Ricardo Sanchez. Ricardo?
Thank you. Saved the best report for last year. No. Let's start with discussion and consideration of proposed language for a policy statement by the board regarding warning labels and prescription labels for oral chemotherapy drugs. And you all have attachment 1, which will give you some info. A little background is in 2017 and 2018, Chapman University pharmacy students and faculty appeared before the committee to discuss proper handling and disposal of oral chemotherapy medications. The group advocated a requirement for pharmacies to place a standardized hazard symbol on prescription labels for NIOSH designated hazardous drugs. In October 2018, the committee suggested the group focus on increased stakeholder awareness rather than seeking a mandated requirement for labels. Members also directed staff to develop a possible board policy statement regarding proper handling and disposal of oral chemotherapy drugs. Some of the discussions we had was at our January 8, 2019 meeting, staff presented language for a proposed policy statement regarding the hazardous drug symbol on prescription labels for chemotherapy medication. And that is your attachment 1 for the committee to see. The committee requested a minor word change and clarification regarding an abbreviation for oral chemotherapy. The committee directed staff to work with myself and requested modifications. In addition, the committee voted to recommend the board adopt the statement as modified by the committee. So if you could all look at the statement in attachment 1. I want to see if you guys would adopt that.
Okay, cool.
Do we need
So-
do we need a motion for that?
But I give it to
We- we-
public?
we need-
or-
Okay, public.
Recommendation you want to recommend is
I want to, I want to
Okay.
get a recommendation to adopt the, our staff's
right.
recommendation.
Board members, comments? Any comments from the public? Danny? Okay, come on up. Turn it on. I think you have to turn the microphone.
So we also, we were appreciative of the policy statement. We'd be happy to help disseminate this information out to our members as well. Support the policy statement.
Okay, any other public comment? This is the committee recommendation. No other board members comment? If not, okay. For all those who in favor, please raise your hand. Unanimous. Okay, recommendation is adopted.
Okay, let's move on to section number B, summary of staff report on the Ask an Inspector program. A little background, at the October 2018 committee meeting, the committee requested staff report on the Ask an Inspector program. Specifically, members asked about the number of calls received and the top 10 type of calls. The committee also directed staff to report annually on the program starting January 2019. Some other discussions was that staff reported inspectors responded to a total of 3,257 inquiries to ask an inspector between January 1st and December 20th, 2018. Inquiries were classified into 77 types. The top 10 types of inquiries are listed below, and as you could see, controlled substance was the one that they called the most on, and followed by pharmacy practice, which and we have a whole list of those on attachment 2 for the board to see. And on attachment 2, you'll see that it contains a list of the 77 types of Ask Inspector inquiries and the number of inquiries for each type in 2018, and a draft of questions and answers from the program. Based on the information provided, staff recommended publishing frequently asked questions in the script and the website to address the most common questions. This could result in less calls to ask a pharmacist. Staff also provided an overview of the program, asked an inspector, and is staffed by one inspector each week, so that's what we have right now. The duty inspector is available to answer phone calls from 8 a.m. to 4:30 p.m. Tuesdays and Thursdays. In addition, the inspectors respond to faxed and emailed questions all week long and spend an additional 2 to 3 days the following week researching and responding to questions. The committee discussed possible changes in the hours inspectors are available to respond to phone calls, to fewer hours, but more days per week. The committee directed staff to report back on the possibility of extending the program based on available resources. And I don't know if Ann wants to elaborate on that.
So we're looking at whether or not we can perhaps change the construct of it so that someone will be available daily for phone calls, but at a reduced time period. So we're looking to see if there would be any negative impacts to that model. So we're still looking at. We plan to have a recommendation at the next committee meeting on where to go.
Yeah, we just want to make sure that if anybody needs to ask those important questions, that we make ourselves available. So that's where we're going with that.
Well, I think with the popularity of this program, it is really more convenient for the licensees to call like Monday to Friday, maybe just 9 to 12. At least you know that every day there's somebody going to respond to your question, as opposed to a lot of times we got questions by licensees, and I would say, why don't you call the inspector? But then he would say, oh, today is Wednesday. I'll wait until tomorrow, and you got to wait another day to do it. You could shorten the hours, but every day you got somebody to do that from a certain period of time. I think it's more accessible.
Michael and do we have any statistic as time go by? Do we have more call or do we have less call now as the program going along?
So part of what we hope to do is do some basic post-implementation management of the program, so I don't have that data for you right now. But we need to look at not only volumes and trends, but I think we also need to look at who is calling, because when we initially started, the majority of the calls were not actually from pharmacists, they were from attorneys. So it's not only it's not only the volume, but it's also the audiences that are using this. And the other thing is that it lends itself to then creating opportunities where there may be a better mechanism to educate. So this is wonderful for the person that's on the receiving end of the call, but if one person has the call, if you look at 22% of the calls are related to controlled substances, it begs the question, where is there perhaps a gap in the education, and how can we be developing the education to address the larger audience instead of just the person on the call?
That's what I'm looking for, yeah. So, if you know what the topic is, then you could educate them so you will have decreased the amount of call the same subject.
Yeah, and again, we're questions and answers. Sometimes you get same question asked, and we're putting that in the script. We're putting that on our website, and hopefully that will help educate some of our licensees also. So we're going to keep improving on this, but we'd like to make it available for the public. Anybody
Yeah, I like the idea, like Victor said, that at least they know that they can call in every day instead of, because, I remember us talking about this some time ago, but at least if you get those calls every day for a few hours, maybe it can be reduced, but I'd like to see it go to that.
Okay, that's it.
The only thing I was going to add is the chief inspectors, chief of enforcement, whatever their title was, they did make the comment that when the inspector was on duty, like from 8 to 4, like on Tuesday, that actually it wasn't just Tuesday, because then like it took them like Wednesday, Thursday, Friday, sometimes back to Monday to get through and answer all those calls. So they're like so it's not just a 1 day, 8 hour thing, it's more than that.
Yeah, they have to do obviously some research, but on a lot of it, some of the questions keep popping up. They're the same, and hopefully it'll, improve as we keep answering those questions. So.
And I think the other thing, didn't we talk about, Ricardo, was looking really at what the questions were, and as an education committee, like how can we take those and...
Yeah, and the staff was going to get back to us, and they're going to research some of that as far as the frequently asked questions. And we have a sample of those that we're going to get into right now.
Steve Gray, pharmacist. In looking at the frequently asked questions, several of us that teach pharmacy law had some serious concerns. And it may be just a matter of structure of the way they're looked at. The Communications Committee has typically had a mandate to communicate to the public, to increase the awareness of what the public. The frequently asked questions, most of those were from practitioners, from pharmacists and so forth. We believe it would be better then, since most of them were asking, is it legal to do this? How do you do this? And so forth, if those were reviewed by the Enforcement Committee rather than the Communications Committee. And part of the reason for that is the audience for the Enforcement Committee is quite different than the audience for the Communications Committee. And when I say audience, I'm talking about who's there, who's participating, and so forth. Not very many pharmacy law educators, attorneys that represent pharmacists and so forth go to the Communications Committee, but a lot of them pay attention more to the Enforcement Committee. And we noticed some serious deficiencies in the FAQs that were published as drafts and in the committee materials. And so in making sure that the board has really good input on those FAQs, if they're put out there for input, we think it would be better if it was turned over to the Enforcement Committee.
So I say maybe they never attended one of our meetings. They're exciting. That's all.
I think don't get me wrong, I think the Communications Committee serves a very vital purpose in educating the public and educating non-practitioners, and even educating perhaps practitioners about things that are not necessarily related to the legal rules of how they practice and so forth. So if they don't know about a particular healthcare crisis, sometimes we get so involved in just practicing we don't realize the bigger healthcare picture. I think that could be very well done by the Communications Committee in educating everybody about general rules. I just think that if those FAQs were put into the Communications Committee to get input, I think the value of the input that the board would get on them would be better if it was reviewed at an Enforcement Committee process.
Oh, well, we'd welcome them with open arms, Steve. Thanks for the additional burden.
Yeah.
I thought you...
Like giving it to him, is that what you're saying?
That might be insightful and serve both our purposes.
Yeah, and then your report can be 15 pages instead of 13.
Oh, you'd love every
If I can
Okay.
just clarify that the intent of that was so that committee members would see the types of questions that are doing. They have not been fully vetted. It was to really just help provide some context to the program, and that's why it says draft, and we tried to reiterate that it's draft, but it was just to give a flavor.
Yeah. And there's sample questions on your attachment. So 3.
Right, and it is going back to the committee.
Yeah.
further, so.
Okay. Any questions? No? Okay. Can we move on? Okay, let's go on to number C, summary of staff report on surveys performed after pharmacy inspections. A little background, at the October 2018 committee meeting, the committee directed staff to report on follow-up surveys of pharmacies performed after inspections. The committee also directed staff to report annually on the inspections beginning January 2019. This part of the discussion was at our meeting was staff reported supervising inspectors surveyed 67 licensees after they were inspected in 2018. The surveys asked pharmacies to rate the inspectors in 5 areas. The responses are summarized below, and you all have a list there, so you can look at them. And the surveys also solicited comments from pharmacies on the inspection process. Staff noted that more than 95% of the survey responses were positive. Copies of the survey form and comments received from pharmacies are in your attachment 3 for all the board to see. Staff said the surveys are a small sample of the total number of inspections performed annually. Staff explained the surveys are an informal means to get an idea of how inspectors were doing in the field. Moving forward, supervising inspectors plan to build on the program by increasing the number of surveys and collecting more data from pharmacies about the inspection process. Staff also suggested creating a fact sheet or brochure about the inspection process that could be given to pharmacies at the time of inspection and posted online. The fact sheet would include information about the inspection process and what is expected of both the inspector and the licensee. It also would provide information on how licensees could contact the board with concerns or feedback about the inspection. The committee asked how negative comments on surveys are followed up. In addition, the committee asked about procedures to enable whistleblowers to voice a complaint about fear of retaliation. Currently, staff said supervising inspectors review the surveys and address negative comments with the individual inspectors. In addition, DCA's website provides information on how to file a complaint about any DCA agency, a DCA acronym for Department of Consumer Affairs, which would be referred to the DCA's Division of Investigations. A link to the DCA complaint process could be added to the board's website. And again, this is more of a way to give the licensees or the public an ability to complain, and go directly to investigations. In addition, the board could provide other ways besides inspection surveys to solicit feedback about inspections from pharmacies. The information could be provided in the fact sheet given to pharmacies at the time of inspection. Recent update is in response to committee questions, staff collected additional data for a comparison of the surveys and inspections in 2018. The surveys were completed between January 1st and November 30th, 2018. Total number of surveys after complaint inspections, January 1st through November 30th, 2018 was 67. Total number of inspections completed January 1st through November 30th, 2018, 2,448. Any questions?
Well, I think this is a bogus report. And I mean, it looks like something I'd turn in,
I'm telling you, we're just a little bit more exciting.
And I must just get calls from this second column here, strongly disagree or et cetera. I don't mean to fault the staff, the board, or anything, or the inspectors. God knows. No, I think that. There's no anonymity to these reports, and it seems to me that while I haven't heard, a lot of people have surveys that go along well, and they get positive reports back, and I get a lot of positive feedback too, but I get a lot of negative feedback, and I don't see it reflected here, and I think this is kind of an analogy of saying, how'd your IRS auditor do? You're not going to send it in because you're afraid of retaliation. And this is one of the things we want to move forward away from on the board. One of the things, like with the filling of narcotic prescriptions in the last couple weeks, everybody's afraid of the board. They're afraid of a DCA. They're not going to send anything into the DCA because they think it's a conspiracy against them. And this has been a big problem that some of us hear about on the board. And so I think that I can't accept this with open arms. I don't think that there's I don't think it's this good. I don't think it's bad, but I don't think it's this good. And so that's one of the reasons that I like the idea of having an anonymous reporting. I don't want to insult inspectors, but I'd like to have an honest assessment. There are some inspectors out there. Maybe they're just this one and this second column. I don't know, but I'm serious about having good feedback to us so that we can assess things as we go forward. I think that's important.
So I want to touch on this because this is a topic that I've brought up before at previous board meetings. I'm happy to say that there is a noticeable change due to President Victor Law's vision of more of an education and less punitive. That is being seen and starting to be accepted among our membership. It's slow, but it's going. And so I do want to say that I agree with Board Member Shad's desire to have these be pretty anonymous. I will say that I've said this before, one of my main jobs at CPHA is to help repair that trust. And I've said that before here, and I'll keep saying it. And one of the things that I've done personally for the board's kind of, reduce the heartache among the board, I've been asking our members to come to me first before they come to you to see if I can help address before they have to ask an inspector, before they have to call Alan or Ann at her home. No, I'm kidding. I didn't.
You did publish that number, right?
I did not. No, not yet. No. And so what I've been trying to do is essentially triage these complaints that are that could be addressed a little bit earlier to help kind of, again, rebuild that trust, because there is a perception out there that trust has been damaged over the last few years. But like I said, it is repairing itself. It's a slow repair, but it is repairing itself. And I'd be happy to help, whether it's enforcement, whether it's communication, whatever committee, whether it's the interim executive officer, I'd be happy to help provide that feedback or start providing that feedback in a way that's more helpful for the board based on what I get in terms of feedback, and help so that way we can get to that sooner. I will say that and this shouldn't shock anybody. They will be more honest with me than they will be with the board. And sometimes that's, it's just a function of how it works. And I try to do my due diligence in investigating exactly what is being complained about before I reach out to somebody on the board staff about this. Now, I will admit I sometimes don't have all the information, but I do make an effort to try and provide as complete a picture as possible. And I'd be happy to increase that role in a manner that's more helpful for the board. And however you guys want to do this, I know that we have a commitment to working with the board because the board is not our enemy. The board is it's a regulator and a licensee relationship. It's not always the best, but it has to work. And the more we make it work, the better it is for both you guys and our side. So,
Danny, get the message out. We work with the licensee, but at the same time, if the licensee have intent to violate those regulations, we lean on hard. When the intention is to on purpose, we will lean them hard.
Absolutely. And I will stand here today and say we won't support any actions by licensees that are intentionally skirting the law.
Yeah.
I think the majority of feedback that I get is related more towards either misunderstanding of communications or just outright, the board's wrong or the inspector's wrong or something to that effect. We don't defend illegal behavior or bad behavior, and we make that a point to our members to say that.
Yeah, and we will not tolerate it either.
Absolutely.
I just wanted to say, when I saw the results here, I was like Alan. I said, really? Because one of the things that has been really important to us is that that inspections aren't always punitive, that there's an educational factor in there, because I can remember when I was in the stores and inspector came in, it was also, I think it was actually even more about educating than it was punitive. So, so anyway, I would love that this would be true, though.
I look forward to it being true.
Yeah, and as I mentioned, I do believe that this is, I think the statistics that are being shown reflect improvement. I don't know if I'd say that we're there or that we're done. I probably wouldn't say that, but it is improving, and I do want to make sure that is clear.
Yeah, and
Well,
responding to Ellen.
it is improving, but obviously, if you could tell from the last survey that you see, out of like 2,500 inspection, you only got 67 surveys back.
Well, I mean, that part of that I would
there's
imagine.
an issue.
Part of that I would imagine is if there's that mentality out there that you don't usually complete a customer satisfaction survey unless something is wrong.
That's right. It's somebody have the independent, more objective than subjective. I mean, that's why we have Mr. Ricardo Sanchez, the head of the new task right now. Things were different. We're going to have something in place. They're going to figure out a thing
Absolutely.
that will be independently, how to conduct a survey without directly being subjective. I mean, like you said,
and as I
I'm
mentioned,
going to be
if we
inspected by
can-
that inspector,
Yeah.
and the supervising director is above me. Will I dare to say anything? No, I won't.
Well, and as I
Of course,
mentioned,
I would
if-
say, yes, he was great. Oh, everything is great, 100%. That was good.
And as I mentioned, if
understand.
we can help, be more direct or more clear about the feedback, please let us know. We'd be happy to do that.
I could say as we move forward, just like from this year, 2019 onwards, yes, we're heading to the right direction. We hear you. Mr. Ricardo Sanchez heard that. There will be some new thing in place that they will review that and find a mechanism to conduct the correct survey that will get the real picture of
Right.
what it's like. Thank you.
Thank you, guys.
Okay.
Any more comments?
I'm just going to say something real quick. As a state investigator, also we get these cases. It's easy to call in anonymously, and you get into the vindictive stuff. I just want to hurt your business, and I want to hurt you, and so forth. We're dealing with the public safety also. We have some of these pharmacies that we hear the cases all the time where they take half the OxyContins, or we have a lot of a lot of danger to the public. What if it's an employee wanting to do an anonymous call on their supervisor or something like that, right?
Oh,
Or
right,
Call
yeah.
it in and say, listen, there's some danger here. This is being flooded here, or whatever. With all these stolen drugs. I understand the anonymous stuff, but as being in law enforcement, you have to have some facts too. So you have to have something to be able to follow up on. It's hard.
Absolutely. And when I was perhaps a little bit blunt in that, but I don't think those are correct. 97%,
It was a sample, is all it was. It was like I'm not sure how they got the sample, but it was a staff
they
worked
sent
on it.
these
It
in
was
and
a
thought
sample
they'd
of
get
it.
plus points, is what it is.
Yeah.
But no, and you're absolutely right. There can be vindictiveness, falsehoods, etc. Like I can send in something bad about Stan's Pharmacy just because
Exactly, and then how
jealous
is
of
he,
his
how is he going to
success.
defend himself based on just an accusation? He's going to have an inspector come out, review his whole business, disrupt his work and so forth, based on a I've just made a phone call.
But,
I mean,
of course, the public
but
can do
as
that
an
now.
inspector, though, when you do get that information, if it's credible, then there's something to it. But they have to evaluate that to say, okay, you're calling in, you're making a complaint, and you're actually giving me copies of this, or this is giving me some sort of proof. Something to go on. But that would be the inspector to evaluate that. I think you have to give them also an ability to follow up on that.
I think besides the supervising inspectors who got to report, maybe the executive officers should have to report too, so the oversight by other people, if the other person hasn't done anything about it.
Maybe some instructions on if you are going to call anonymously, this is what we would prefer you send in. You know, how's about the who, what, where, when, why? Facts, something. I know at DMV Investigations we have a little sheet that gives you the, what information we're looking for. Maybe they can fill in the boxes, something that would help out the inspectors to narrow down their complaint if there's something to look at. That you see a pattern, you can see a pattern, then it would direct our people to look at a licensee. Just a suggestion. Okay, can we move on? Okay, let's go to number D, discussion and consideration of current and potential public education materials and activities in preparation for 2020 Sunset Review Report. A little background, the Board Sunset Review Report 2016 discusses key programs for communication and education of the public and licensees. Our discussion is in anticipation of the upcoming Sunset Review in 2020. Staff reviewed some of the communication and public education resources currently used by the board. In addition, staff requested feedback on possible additional activities and materials, including revised updated brochures, notice to consumers, point to your language, etc., new brochures or videos, how to dispose of unwanted medications, how to prepare for a declared disaster, etc., additional social media accounts, Facebook, Instagram, YouTube, etc., communication and public education, additional CE webinars, a PowerPoint overview of the board for public outreach events, staff presence with consumer brochures and other materials at community health fairs, senior events, and other public gatherings. The committee suggested staff work on making the board's website more user-friendly and making online materials easier to find. A copy of the public information policies from the Sunset Report is in your attachment 4. Any questions?
I have a curiosity.
Sure.
So, where are you? Thank you. So where are we in this process, and what is your timeline for the Sunset Review process, as far as everything that you have to gather and assemble and present?
So,
Here, I'm sorry. Now do it.
yeah. I believe that we'll receive an invitation to participate in the process, but looking at how how it went last time and things like that, we will probably start our efforts. Data collection is the primary because that really helps then to drive the rest of the story, and it's historically been the last 4 fiscal years, so that won't be done until the end of June. We'll try to start pulling some of the prior fiscal years just to make sure that our systems are in place and we're ready to go. And then hopefully we'll have the data collected by the July board meeting. Ideally, we're going to have a draft report to the board for the November board meeting. To allow the board an opportunity to review it. With respect to some of the specific elements that are highlighted in the chair report, we are working towards doing some of these things already. We're not going to have it all achieved. I don't want to make promises that we're not going to be able to meet, but we are moving forward to create some additional webinars. The law and ethics one is actually under review. The script for the ethics program is actually under review right now by council. At the February 23rd meeting, we're having the webcast for portions of the day-long training so that some of that can also be made into webinars so that people that are unable to attend in person will be able to get access to that information. So we are moving forward with trying to achieve some of these, refresh things as well so that when we are ready to compile our Sunset Review report and submit it to the board for consideration, we will have met some of the milestones that are established.
So would you consider in your EO's report at board meetings adding a little update on where we are in the Sunset Review process for us?
Happy to do so.
Thank you so much.
Okay, no more questions for you. Any questions, public? No? Okay, we'll move on. Discussion and consideration of steps to improve emergency response during declared emergencies. A little background, on November 8, 2018, Acting Governor Gavin Newsom declared a state of emergency in Butte, Los Angeles, and Ventura counties due to wildfires. In Butte County, the Camp Fire forced 5 pharmacies to close because they were destroyed or sustained significant damage. 6 additional pharmacies closed temporarily because of poor air quality. On November 9th, 2018, the board issued a subscriber alert advising licensees about Business and Professions Code, BPC sections 4062 and 4064. These provisions are intended to help pharmacists provide essential health care for patients who are displaced in an emergency. On November 20th, the board issued a second alert explaining the board waived pharmacy law requirements that may be impossible to meet in an emergency, including security prescription forms for controlled substances under the BPC sections 4062 subsection B. The alert also directed pharmacists to the board's official disaster response policy statement regarding emergency care for patients in declared disasters. The board also issued a subscriber alert in November 21st and December 3rd about the Emergency Prescription Assistance Program, EPAP, which helps uninsured patients in disaster areas obtain prescription medications at no cost. Board staff also collaborated with other state agencies during the disaster, including the California Department of Public Health and the Office of Emergency Services. At the December 19, 2018 Licensing Committee meeting, CDPH staff presented information regarding the provision of pharmacy services during a declared disaster. The Licensing Committee recommended the information also be presented to the Communication and Public Education Committee to consider educational material to develop and ways to improve the board's communication during a disaster. And our discussion, Tom Ahrens, is that the way you pronounce? Of the CDPH Emergency Preparedness Office informed our committee about the challenges in providing healthcare and pharmacy services for residents evacuated during the Camp Fire disaster. There's a whole key issues here, and you all have a list of them there. You know, from residents who were forced to evacuate with little time to pack, prescription medications, to patients did not have money available or could not afford to cover co-pays for medications. And you have, he did a really good presentation. Committee members and staff discussed possible solutions and steps the boards could take to improve delivery of healthcare and pharmacy services during disasters, including like create free CE for pharmacies on what to do before and during a disaster, prepare fact sheets for consumers on how to prepare for a disaster, reach out to pharmacy chains and professional organizations to help disseminate information. And again, you have a list there. And it was very well received by our committee. It was very informative. And the committee directed staff to report back with recommendations on implementing improvements to the board's communications during declared disasters. Attachment 5 includes the text of BPC sections 4062 and 4064, copies of 4 subscriber alerts issued during the recent declared disaster, an excerpt from the licensing committee minutes, and a copy of the board's disaster response policy statement. And that's on your packet for you to review. Any questions?
I think the idea of creating free CE for pharmacists on what to do before and during a disaster is a great idea. Of course, it's easier said than done. Is that a possibility? I know it's a possibility, but is it something that we can do with a degree of rapidity?
So we'll be bringing in experts, and actually Tom Ahrens has already agreed to assist us in developing it, and that's his area of expertise. So I think it is achievable.
Well, great.
Along the same lines, I'm not quite sure if this is off topic, Counselor, in reference to CEs for pharmacists. Can pharmacists get continuing education credits for volunteering in a homeless shelter or something like that? I don't know if this is off talk.
I don't think under its current, under the current organizational scheme, probably for this topic, I think I would, I assume the focus is on, in an emergency response.
Yeah, there's
that
emergency response.
Could they
and
basically get
Could they go to a
CE
homeless shelter? Could they go to
for-
a local clinic under the emergency response?
in an emergency situation?
And get
I don't think
CEs.
that would be authorized from my recollection of your current CE, but that doesn't mean you couldn't consider that.
Because if we're talking about emergencies, it might be something we might want to include. Because I'm sure, those that are most vulnerable and need the help probably don't have the help. And if our pharmacists knew they could, help out at a shelter or some, thing like that, it might be a benefit to all parties. Something to consider.
So at the staff level, we can research and maybe see there might actually be other states or other agencies that are already doing that, and we can bring that back to the committee if that's agreeable with maybe some suggestions.
The question, I hope other committees and other agencies are doing it, but I don't really care if they're not doing it or are doing it. The question is, can we do it?
Oh, absolutely. But if there's absolutely, I'm hearing what you're saying, and so we'll come up with some proposals. But if something already exists, then we don't have to recreate. We can leverage what someone else has done.
I appreciate that.
Okay, any other questions? Nope, seeing none, let's move on. Update on communication and public education activities by board staff. Can somebody turn their mic off? Someone else? Because I think there should only be like 3 of them on. Okay. I thought it was Alan back there doing it. I'm watching you. You wait till your next report. Just joking. Okay, update on communication and public education activities by the board staff. That's your attachments 6 and 7 in your folder. The script, current issue of the newsletter, was published online December 2018. Staff is working, now we're running out here, working on the next issue, which will focus on new pharmacy laws. Project update, Outfront Media signed a no-cost contract on January 8, 2019 for 5 billboards about prescription drug abuse. The contracts calls for billboards in the Sacramento, Fresno, and Los Angeles markets. Specific locations will be determined based on availability. Outfront has informed board staff that Outfront will print and ship the proofs to billboard sites in 2 to 4 weeks. This has taken forever, and we thank you so much, Ryan. In addition, the board established its first social media account in December on Twitter. Visitors can visit the board's Twitter feed at twitter.com/CA Farm Board. Okay, news media, the board executive officer and public information officer participated in an interview or provided background information in response to media inquiries, and that's in attachment 6, and you can get the list on that. Public outreach, board inspectors and staff provided training at the board's December 8, 2018 CE Forum on prescription drug abuse and drug diversion at Santa Barbara Community College in Santa Barbara. A total of 94 pharmacists attended and received CE at the event. The board has tentatively scheduled the next forum for February 23rd in Fresno and is working to schedule another in San Diego in April. Additional public outreach activities by board inspectors and staff are in your attachment 7. And then attachment 8 is your summary of discussions of news or journal articles. News articles on pharmacy issues that may be of interest to the board are also on attachment 8. Future meetings, Wednesday, April 10th, 2019, Tuesday, June 25th, 2019, and Wednesday, October 9th, 2019. And with that, we're done. Any questions?
Okay, well, thank you, Ricardo, and your committee members for your work. And let's move on to the next agenda item, is the Organization Development Committee, which has 2 members only. That is me and Greg Lippy. Item A, yes. we need a lot of help. Budget report update, fiscal year 2018 and 2019. So on June 28, 2018, the governor signed the budget for fiscal year 2018 and 19. The new budget year began July 1st, 2018. The board spending authorization for the year is $26 million, roughly, which is an 11.3% increase from the prior year. Now, this increase includes the following: around $1.1 million for one-time costs for the relocation of the board's office, about $685,000 to fund 2 inspector and 2 AGPA positions to perform thorough compounding and other enforcement functions, around $423,000 to fund 3 positions to implement new legislation, including statutes of 2017 AB 401, Chapter 623, statutes of 2017 SB 351, and Chapter 647, statutes of 2017 SB 443. Around $816,000 in employer retirement contributions and employee compensation, around $134,000 to fund equipment purchases, about $264,000 in pro rata, about $112,000 in employer retirement contributions, $507,000 in boards and bureaus workload PCPs, $131,000 in other post-employment benefits. There continues to be a delay in receiving budget information from the department due to the newly implemented fiscal accounting system. Board staff have been advised that until the fiscal system is able to close out the prior fiscal year 17-18, no interim budget figures can be produced by the system. So we're hopeful that when the prior year closes out, we'll be able to resume providing the board with current year expenditures. Based on the limited reporting available, the board believes it has received around $11 million in revenues originating from the following. So you can see the chart right there on the page 2 of 3. And below is a summary of the fund condition report prepared by the department with the available budget reports. The fund condition assumes that the new fees will be in place no later than January 1st, 2020. So you can see the table with the fund condition. Attachment 1 includes the detailed budget charts for board revenue, as well as the fund conditions prepared by the government. Any board members comment? Public comments? If not, I move to item B, board member reimbursement and attendance information on attachment 2. Now, board members' basic reimbursement for travel expenses and per diem payments. It is important to note that these figures only represent hours and travel expenses where reimbursement was sought. It is not uncommon for board members to waive the per diem payments or only request partial reimbursement of travel expenses. And the reimbursement and board member attendance information are provided in attachment 2. Any comments from board members? Yes, Stan.
So I am more than curious, mostly concerned about the attendance of 2 board members in particular. One board member has been here exactly 1% of the time, and another board member has been here exactly 33% of the time. Besides the ripple effect, committees, and how it might affect the committee and the size of the committee and in the event that when they do come to meetings, there's no continuity. If somebody's coming 33% of the time, there's no continuity in their attendance, and therefore no continuity in them being aware of the board's dealings. And I'm not sure if the attorneys have any thoughts about this, but with regard to this organization, what can this organization do about what we perceive to be, or let me rephrase that, what I perceive to be irresponsible behavior with regards to attendance?
Well, I could speak to that first, Stan. I saw the figures too, and in fact, I did reach out to these two board members. For board members Khan, he told me that because of his schedule, actually, it would be very difficult for him to schedule any further board meetings with us. So he need to talk to me about a possibility of this resignation from the board.
Well, I think the
Because
possibility is.
he just say if he couldn't figure it, he might as well just resign from the board. So this is being addressed to, and also on the other board members, Munoz, which happened. Some of the committee meetings fell on the Tuesday or Wednesday, which happens to be her city council meeting also. So it's hard for her to get away from that particular night, or even if she comes in, she can attend one day and cannot attend the second day. So in doing so, me and interim executive officer Ann, we have talked about it. So we try to consolidate some of the committee meeting, especially on the one that we have the public members serve on, those like Public Education and Legislation Committee. So we'll try to fine tune them, and hopefully that we could squeeze them on, let's say the Ledge Committee, squeeze them on certain days where we have the board meeting as well. So that people, so she could come and attend both the committee meeting and the board meeting at the same time, and that would take care of the issue. So I did pay attention to those two.
And I know it's hard for her. She does, the board meetings, but she when she does come, she's very well prepared, and she participates. Yeah.
What I'm saying is, every organization that all of us are part of, the key thing about being part of an organization is attending. Wanting to attend or having good intentions are great, but attendance, whether it's Rotary, Kiwanis, or even the pharmacy board. And so that's all I got to say about that.
Yep, thank you for your comment, and I did.
I do have a comment also about that.
Yes.
And I agree with you also, Stan, on that. One of the things we've done okay, or things that we could do better, something I brought up in the past, is one, the timing of the meetings. Having meetings at 8 o'clock in the morning probably aren't the best time to have them, because that forces you to have to fly the night before for those people who are not local. If you had the meeting at, say, 10 o'clock, everyone could fly in the same day. Instead of taking 2 or 3 days off of work or your duties, you could only take, one day. And having, which I like also, the committee meetings prior to the regular scheduled meetings condenses it. So there's, it's not just, yes, we all have a commitment. We made a commitment on this board. We're all volunteers. But some of the structural things we can change to enhance, attendance, I think we need to look at even a little bit deeper.
Okay. Yeah, Debbie?
I was thinking that we had kind of, because I fly up usually the morning of, and we have some that start at 9, but it seems like more often than not, we do start at 10.
No, so we started that, and it has not been consistent.
Okay.
And that's the challenge. And a consistent policy, I think we've had better attendance, and people wouldn't have to take off, days off of work, or from family or kids or whatever, obligation you do have. And I think we could change those structural things. Hopefully, that will come out to where people can attend more meetings. So, just a thought.
I think the rationale that we start with the meeting at 10 o'clock is to allow the subcommittee to have the meeting before the regular board meeting. So that way we would squeeze in the time for these members who could attend both meetings at the same time. So that's the rationale behind it. And I, like I said, I did address the issue because I saw that what you have seen, and I tried to take care of it as soon as I could. Yeah, so I am on top of that.
I just want to
Thank you.
add something to the organizational development, and that is to notify everybody that on a monthly basis, Victor and I have been reviewing all sites and fines with the executive officer and supervising inspectors with the idea of adherence towards the policy of education versus punishment. And we've been making some strides in that area, I believe.
That's something that you guys may not have seen, but me and Greg every month will take those citations and we review that with the interim executive officer and also the supervising inspectors. We review them to see what directions we're going, and we give them feedback to see what directions they should be going. So this is something that we've been doing the last few months, without you guys knowing it.
Well, good,
And-
thank you.
And just so that I feel better about this, those are all closed and resolved citations, right?
Yeah, they're closed. They're all closed
They're not
cases.
pending.
They're not
Nothing
pending,
pending.
and everything
Fair
is not pending.
Thank you.
Can I add one other thing?
Yes.
I think it's important that we. Thank you. I think it's important that we try to cover as much of the state as possible, and I appreciate your attempts to do that. So it's my hope that we have sign-in sheets, and it's my hope that, I don't know if it's necessary to report the attendance as a board attachment, but I'm curious to know what the attendance is as we go from pillar to post in the state. Again, I think it's important to make ourselves available. However, as I look out here in San Francisco, I see, the regulars who would come to the meetings, usually no matter where they are, and it's the first row or two. And then I'm not quite sure how many other people we have in the audience. But what I am positive about is the expense coming here is significant, and the amount of staff time and staff effort. I mean, I thought that a plane had landed and that we were just storing some luggage here because a plane had landed, and Laura tells me that is the equipment that we are schlepping here from Sacramento. And so it's a huge effort, and I thank everybody for the effort. I just hope that that we're doing something that is valuable to our licensees.
Not only that, but I think Fresno was a bit of a challenge.
Are you talking about the city or us going there for the meeting?
Well,
no
going
offense
there.
at this meeting.
Well, I have one solution for that. I think nowadays, as I understand the meeting, we provided 6 free CE unit, but I think we should limit how many CE unit they could do online. Then you would have a lot more people come attending this 6 unit. So Danny, tell your member make good use of it. So that's quite a few dollars in there, okay?
So one quick comment with Stan. I think I'm an analytical person. I love numbers because those actually help you kind of figure out direction. I'd be curious to see, maybe a question for Ann, what the attendance rate is when this board leaves out of Sacramento versus the attendance rate for when we're in Sacramento. And attendance rate on 2 different parts. One, not just the board members, and we do have sign-in sheets, members of the public and constituents and stakeholders. And if the numbers bear out that there's a drop-off when we're out of Sacramento, are we really doing a public benefit? I mean, I understand what the goal is. We want to give people in Northern California and Southern California the opportunity to participate. But if we're not achieving that goal, we might want to rethink that strategy. And I think it's a great point, Stan. So thank you.
Well, I understand the concern of the budget restraint. I totally understand that, but I could tell you guys, historically, this board hasn't been viewed as such a professional, friendly to all the licensees. And I could tell you, if you go out to the state to interview the licensees, all of them are afraid to come to the board, afraid to talk to board members because they're afraid of retaliations, they get fined by inspectors or whatnot. But I could tell you, from day one on, beginning 2019, the rationale that I tried to go out across the state to reach out to all the pharmacists across the state is to send them a message that we are moving forward with this board, with the profession, and we are the one trying to help them along. We're not the enemies, okay? We try to help each other out. We wear both hats, even though we're consumer protection, we also do all the stuff for the profession. And I think that the people in attendance here will get the message and get it out. that the next time we have another board meeting, we'll have a lot more people coming and attend the board meetings and to testify in front of the board.
To Albert's point, I absolutely agree that we need more members, pharmacists out here. To that end, we've kind of recreated our communications plan to encourage like much more than we have before. Like I said, I personally am calling people to tell them to please attend. The next. Now it's a little difficult when we don't know where the location of the committee or the board meeting might be. When that is made available, first thing I do is I email them or I call them, say, we need you here, we need you to testify. There's this issue being brought up. So that is being taken care of from our end. On what President Law said about what we don't see, I have to give credit where credit is due, and we thank you for that, because that is something we don't see. And that's something that I try to explain to our members, that some of the stuff that we do, people don't see. They don't see front and center, but we're doing it either behind the scenes. So we are very appreciative of that. And I'm sure I speak for our membership that when we say thank you for that. And like I said, it's been noticed by our membership, by certain sectors of our membership. We're trying to communicate that message as much as possible. I hope that we have more pharmacists attending these board meetings this year than any other previous year, and I'm working to make that possible.
Yeah, and thank you. I'm confident that we will have that a lot better in the future. Okay, any other comments from the public, from board members? If not, I'll move on to the item number C. Discussion and consideration of a change to the board's current policy related to recognition of pharmacists with 50 years of licensures. So I actually request this item be placed on the agenda so the board could discuss the current policy of acknowledging pharmacists who have been licensed in California for 50 years. So you got to think that pharmacists who graduate from pharmacy school with a PharmD and you got your license, probably be at least like 20-something, 30 years old. And plus 50 years in practice, about 80 years old. You start to recognize them. I am hoping that we could get a motion to at least recognize a pharmacist 40 years in practice rather than 50. I don't even know if I could make 50 years. I mean, by myself, by 80, I don't even know if I'll be around here.
Stan made it.
He's one of the exceptions. So I was hoping that you talk about encouraging pharmacists to come to the board, right? So 40 years, I think, may be approachable as opposed to 50 years.
I think that's the prerogative of the chair. I mean, I don't know if we really need a motion to discuss it. If you want to recognize someone from 40 years or 30 years, that's fine. I mean, 50 years, if I'm doing the math right, you're born, that's 19, your pharmacist is 1969, so, 59, 49. So if you've been in 20 years, you started in 1949. And so if you want to do something to move up the date, that's okay with me. I don't think
I'm being Democratic, so. All right, so is it a policy-wise, or you need the motion by the?
I don't know how the original policy was
Was
adopted,
established?
but I think my understanding from just talking to staff is that it's pretty well recognized among the licensees in your community, and that I think it probably warrants a board motion.
Okay.
And then
I'll make the
perhaps,
motion.
There's nothing in statute.
No,
Just-
this is purely.
I think if the chair wants to do something, for recognize a 40-year-old, 35, 25, 10, 1, whatever.
I don't think it hurts to make a motion, so I'll make the motion.
Well, we make it official. All right, great, make the motion. Need a second? Second by Cheryl.
What exactly is the motion?
The motion is to recognize pharmacists after 40 years instead of 50.
Should it be helpful, we send out certificates to people, and then we invite them to attend board meetings, and if they come, then we present them with a pin.
And we're going to get a lot more board members, a lot more participation that way, I would think.
Good idea. Okay, all right. Motion by Greg, second by Cheryl. All those in favor, please raise your hand. Any public comment? Anybody? No?
Just a point of clarification, I was far from 80 when I celebrated my 50th anniversary as a licensed pharmacist.
Well, we know you started when you were 20.
Young. You started young.
Well, Stan, so we got 50 years and 40 years, that's 90, so you're up for next year.
That's right.
Okay, so thank you, everyone, and that's my report.
I actually don't know.
Is it
Well,
passed?
I think we need to revote because
We
you were in the middle of, hands were
Yeah.
going up.
All right,
when-
all right. All those in
Call for
favor,
public
please
comment.
raise your hand again.
Okay, so I'm counting 9. There's 9 for.
they're great.
Okay, all right. This is in
Ricardo,
favor. All right. Oppose?
In the spirit of remote.
One opposed. Okay. Abstain? Okay, motion carried.
I did.
He, does,
I'm a consumer
he doesn't want to agree because he's over 40.
Thank you for pointing that out.
Okay, all right. Let's
I'm
move on
49 on the
to
CPA,
at the last agenda item of today's is the interim executive officer's report. Ann?
So as indicated in the report, we have implemented online credit card renewal payments. It's currently just for technicians. There's been some bugs. We've been working it out. We do have the stats as of January 3rd included in the report. You also see where we will be progressing next, which is to the pharmacist and the advanced pharmacist. The one thing that I want to point out to members is that it's not a smart system. It's really just a vehicle with which to collect a payment. So there are going to be some challenges with it. One is noted in the report specific to pharmacists that want to renew, inactive, or reactivate. There's no mechanisms to program it to be a smart system. So there will be some limitations in the utility of it. And then we will continue on after we hit the pharmacist and the advanced practice pharmacist into the other licensing categories. There has been a pretty, for not advertising it, the number of technicians that have used it is pretty significant. And once all of the bugs are out, we will be advertising it a little bit more. We currently have 14 vacant positions. We have some salary challenges, and as such, we are leaving many of these positions vacant for a little bit longer to achieve a little bit of salary savings. With respect to the update on the relocation of the board's office, it's been delayed. Last week, I was advised that we may not be actually moving until next fiscal year. This is a very interesting process because you're on a bus and not driving it. And so there's a lot of different players involved, and so it's really outside of our control when we do move, but we will continue to keep the Organizational Development Committee apprised as well as the board as we move forward with the process. The stats for the cures usage for the last calendar year are provided. I think it's over 42 million controlled substances prescriptions were reported to cures last year. That's huge. And then the last item on my report, I'm actually going to.
Before you go on to on the cures report, is there any way they could change the policy of changing the password from 90 days to maybe at least like 6 months? Is there something that is in the statute that you have to change it?
I don't think that it's in the statute. I'm happy to ask the question to the DOJ, but they have some very high security standards with which they must meet, and they have to meet not only the state requirements but also federal requirements because the information that's contained within it is so protected. So it may be a function of that, but I'm happy to ask the question.
Yeah, because like sometimes some of the pharmacists they register, but they may not access the system actually for the whole year, but every 3 months you're going to update the and if you don't change it 3 times you log out, and you have to call the department to ask them to unlock to fill it in for you, and that will increase the workload of the employees of DOJ. This is that my point is like that you don't want to waste some of the personnel power.
Yeah, happy to ask the question.
You got interrupted in the middle of your intro, so there's no intro to your intro. So I will now be, presenting, although you all have copies of it and have presumably read it, the CBD letter, the latest in the series, the trilogy. The trilogy is now hopefully complete. I like that it was printed on green paper. I like whoever made that choice. So I don't want to bore you by going through it in any detail because you have the letter in front of you. I will just sort of summarize by saying that the legal terrain regarding marijuana, or what California is now mostly calling cannabis, hemp and CBD that's derived from either of those source materials is very complex, but it's difficult to imagine scenarios in which CBD products, either food products or, purportedly health affirming products, could be lawfully sold, because if they are food additives, you're not allowed to add CBD because CBD is now the subject of an FDA, or is now an ingredient in an FDA-approved drug, which is a controlled substance, and therefore would be considered, adulterating of the drug of the food. And if it's a non-food product, then theoretically you're not supposed to be making any health benefit claims about it. So I suppose you could just sell CBD oil or CBD without saying anything about it, and there's no prohibition on that I can think of, but I don't know how much of a market there is for unclaimed benefit CBD. Now, again, this is all a question of enforcement. It comes down to who, if anybody, is going to do anything about this, and I don't know the answer to that. FDA, now that the federal government is reopened, FDA and DEA may have some things to say about it, given that Epidiolex has made at least some forms of CBD a controlled substance, and FDA has said, as you read from the commissioner's statement, has said that you can't use it for various reasons. This board has said that it's not an enforcement priority, or at least, was that the board or the enforcement committee? I can't remember. I think it was the board. So that's where things kind of stand. I think the sort of upshot is that the public comment that was made at the October meeting was probably misleading, in the sense of implying a greater ability to sell hemp-derived products than was actually the case as of that time under the 2014 Farm Bill. The 2018 Farm Bill makes it more lawful to sell hemp, but that doesn't really directly translate into CBD derived from hemp. In fact, there's a bit of an irony that in California, at least, cannabis edibles, which can only be sold through the cannabis retailer system and all of that, those appear to be can lawfully include CBD, theoretically, at least under state law. The federal law might be different on that. But the California Department of Public Health has been clear in saying that CBD derived from hemp cannot be added to foods outside of that sort of cannabis edibles context. So anyway, it's very complicated. It took 9 pages to say all of that. So that's where we stand. Any questions?
So in essence, if the inspector go into a pharmacy and find there's some CBD oils on the shelf, as long as they say what the purpose is, then we're not going to confiscate them, or we're going to do anything to them.
That's not my decision to make. That's a policy call that would be made by the interim executive officer or by the board as to how you want to instruct inspectors to enforce the law. There is theoretically a federal prohibition and potentially a state prohibition on making health claims or adding CBD to food items, but I don't know how much of a priority. This board has said that's not a priority for you, so that as long as this board has said that, then I presume the inspectors will follow that instruction.
So Josh, question for you. Mm-hmm. So I'm a pharmacist, and I have CBD oil on my shelf, unlabeled in a clear bottle, and I have a sign outside that says, "We carry CBD oil, period." That would fit within the guidelines. Is that correct?
As far as I can tell. I'm flying a little bit blind here because I don't know exactly what the FDA or CDPH would say about that. And those are really this is an area of greatly overlapping jurisdictions, so I'm a little uncomfortable going out too much into hypotheticals that have not yet been addressed. But I believe that as long as you are, as far as I know, there are only 2 current prohibitions, which are adding it to food items or making health claims about it.
Well, it's like some of the dietary supplements too. You sell over there, but they don't put any claims. They just said dietary supplement. They never claim anything. People put it on the shelf to sell it.
Right, and up to now, to the extent the FDA has taken action at all, it's only taken action by way of warning letters issued to, I believe, to the manufacturers, not to the retailers. Maybe, I don't remember exactly, but essentially saying that false advertising, misleading claims about the purported health benefits.
Fred, you have a comment?
Yes.
Be careful.
I'll make this very, very brief. Time is late. I'll make it very, very brief. We had 6 deaths in our community, Marin County. Let me start again. Fred Mayer, pharmacist planning. I was asked to write an article for the Independent Journal circulation, 150,000. And this is the article. One of the biggest problems we had 6 people go to the hospital, including 2 to Kaiser. At our facilities where I live, Smith Ranch, with 300 old geezers like myself. And the issue is they're mixing their drugs with medical cannabis, which again, as the good lawyer said, consists of 2 types of cannabis, Infamata and the other one, sativa, forgetting what it is. But the main purpose in coming to you is the fact that it has 18 major drug interactions. And as a consumer advocate, as a public health pharmacist, I bring it to the board. It's listed in your 4th column over here, the American Pharmacists Association, their January 2018 issue of Pharmacy Today, listed 9 other major drugs besides these 18 that it interacts with. One of the major interaction, having had stroke and having had bypass surgery and also other complications, is Coumadin and warfarin. So I would like to see the board take a look at this article, and I won't belabor it here. I've asked for another meeting on this, a hearing on it, in addition to these things. And do the pharmacists have an obligation to ask the question? They do ask about codeine, sulfas. They ask about alcohol. They ask about, do you smoke? I'd like to see them ask, do you smoke? Because it's an $80 billion industry. It's getting to be there. And besides the Coumadin, it has drug interactions with statins. It also has drug interactions with grapefruit. And so almost all the products, including Viagra, has a little grapefruit sticker. So I give you this just to ask if we can do more education. And again, I see, I may have misheard, Mr. Chairman, but if we're going to get some education in drug abuse, maybe medical cannabis, THC, tetrahydrocannabinol. And this is the first product that Epidiolex that came on the marketplace for kids with seizures. So I just leave it at that. 18 major things, and pharmacists have a duty to warn, and I just bring it to the board as I did before. We did 7 education programs educating healthcare folks like nurses, pharmacists, physicians. We've done 7 of these, and I think this drug interaction is a major issue. And when a Kaiser doctor says to us, 2 of you old geezers are coming to our emergency room every week. I mentioned it to Steve. This is just Marin County with a population of 250,000. There's a lot of us old people. We're only 12% of the population, but we take 43% of all drugs. So I'd like to see some education on this product, and thank you for allowing me to address the board.
Thank you, Fred. Danny?
So I have 2 questions. One is directed at Josh when he's done. So the first question I have is to you, Josh. So I read your letter, all 9 pages of it. What's not clear to me yet, and what I'm hoping you're able to clarify is, based on what you've explained here, is there, under your understanding, combined with the board's non-priority of enforcement, are pharmacists able to sell CBD oil in a location that's outside of the pharmacy counter, but within the actual physical structure of where that pharmacy is located?
There's no legal answer to that question.
Okay.
Danny, just really quick, I walked over to Josh and asked him a question. I said, are pharmacists legally allowed to prescribe CBD oil?
Well, that gets to my second question. Yeah.
And because it goes back to the second part, if you can't give a consultation on it, because you can't talk about what's good or bad by law, if I'm reading your memo correctly. Ethically, pharmacists wouldn't be able to do it.
So I guess what I'm asking is, so I'm talking about in a pharmacy where you have the pharmacy counter, you have your controls, your all the other stuff, but then there's another part of the pharmacy where they sell candy bars or other items that are not of a drug nature. That's where I'm kind of asking, and so he just told me that there's no legal answer, I guess. My second question then would be to Ann, is given the non-enforcement of priority of the board, if the FDA or CDPH for that matter decided to have some sort of enforcement action against a licensed pharmacist on this issue, would the board then be compelled to also include some sort of enforcement action against that pharmacist?
I'm going to defer to Joshua in the room.
Okay. I'm sorry, once you said Ann, I stopped listening. What was the question?
The question is, if another regulator takes action against the sale of this product, is the board then compelled to similarly take action?
No, the board's never compelled to take action against any licensee. It's always a matter of discretion. The board would have a basis for discipline, presumably, but whether it would take action or not is always the board's decision.
Okay, thank you very much.
Okay, any other comments from the public? Board members? Well, thank you, Ann, for the report. And I think we will adjourn for today and reconvene tomorrow at 9 a.m. Okay, meeting adjourned.